Hello, everyone, and welcome. Today, we'll be diving into the world of gallbladder, pancreatic, and bile duct dysfunction. This presentation is brought to you by Newton TV, designed to help you study smart. Let's get started. Before we delve into the dysfunctions, let's quickly review the anatomy. This diagram illustrates the liver, gallbladder, pancreas, and duodenum, along with their associated ducts. Understanding the normal anatomy is crucial for recognizing abnormalities. Now, let's focus on the gallbladder. Its primary function is to store bile, which is synthesized in the liver and helps emulsify fats. The gallbladder releases bile into the cystic duct in response to cholecystokinin, a hormone from the small intestine. Remember, cholelithiasis refers to gallstones, and cholecystitis is inflammation of the gallbladder. This diagram illustrates various gallbladder dysfunctions. Note the location of gallstones in the cystic duct, leading to cholecystitis. Choledocholithiasis, or stones in the common bile duct, can cause a backup of bile into the gallbladder and liver. Motility disturbances and stasis of bile are also key factors in gallbladder dysfunction. Continuing our discussion on gallbladder dysfunction, let's consider biliary sludge, a precursor to gallstones. Biliary stasis, or delayed emptying of the gallbladder, also contributes to stone formation. Finally, cholangitis occurs when gallstones obstruct the cystic duct, leading to inflammation. Gallstones can cause significant problems. As you can see, they can obstruct the common bile duct, leading to a backup of bile into the liver and potentially hepatic dysfunction. In some cases, they can even migrate into the pancreas, causing pancreatitis. Remember the different types of gallstones: cholesterol, black pigment, and brown pigment. Obstructions of the common bile duct can have serious consequences. These obstructions can be caused by gallstones or even a tumor in the head of the pancreas. A key sign of common bile duct obstruction is jaundice, a yellowing of the skin and eyes. Biliary colic is pain associated with gallbladder or pancreatic disease, most commonly due to gallstones. While pancreatitis is less common, it's often more severe. The pain is typically steady and intense, lasting from 30 minutes to several hours, and is often accompanied by nausea, vomiting, and right upper quadrant pain. Don't forget to check for Murphy's sign. Biliary colic pain often radiates to the scapula and upper thoracic region. Flares are commonly triggered by the ingestion of fatty foods. This can lead to dilation of the biliary tract, elevation of liver enzymes, and elevation of bilirubin. The pancreas has both endocrine and exocrine functions. The exocrine component produces digestive enzymes like lipase, amylase, and peptidases, as well as bicarbonate to neutralize acid in the intestines. These secretions are released into the pancreatic duct, which drains into the common bile duct. Remember that acute pancreatitis, chronic pancreatitis, and pancreatic cancer can all develop in the pancreas. When evaluating gallbladder and pancreatic dysfunction, several labs and tests are helpful. These include checking for elevated WBC, ESR, and CRP, as well as liver function tests. Serum amylase and lipase levels elevate with pancreatic inflammation. Abdominal ultrasound, cholecystogram, and HIDA scans can also provide valuable information. ERCP, or endoscopic retrograde cholangiopancreatography, is an invasive procedure that allows us to visualize the biliary tract. It uses an endoscope with a camera to inspect the anatomy and can even be used to remove obstructive stones and insert a stent. As you can see in the diagram, a catheter is inserted into the ducts during the procedure. Treatment for gallbladder and pancreatic issues varies depending on the specific condition. IV fluids, nasogastric suction, and pain management are often initial steps. Ursodiol can be used to dissolve biliary stones. Cholecystectomy or surgical removal of the gallbladder may be necessary, For pancreatitis, avoiding fat, caffeine, and alcohol is crucial, and nasogastric feedings may be needed. Cholecystitis is acute or chronic inflammation of the gallbladder, often caused by gallstones. In some cases, cholecystectomy is required. Remember that gallstones are more common in women. Empyema, an infection of the gallbladder leading to purulent effusion, is a serious complication. Several factors increase the risk of cholecystitis, including being female, age greater than 40, obesity, a high-calorie diet, and the use of oral contraceptives. Symptoms include episodic colicky pain after eating, pain that may refer to the right scapula, anorexia, a feeling of fullness, and a positive Murphy's sign. This illustration highlights the various conditions we've discussed. Note the gallstone in the cystic duct, leading to cholecystitis. Also, observe the location of cholangitis, inflammation of the common bile duct, and choledocholithiasis, a stone in the common bile duct. When treating cholecystitis, keep in mind that gallbladder rupture can occur, which, while relieving pain, is a serious complication. Opioid analgesics are used for pain management, but morphine and codeine should be avoided as they can cause spasm of the sphincter of Oddi. Hydromorphone dilaudid is a better choice. Acute pancreatitis is a serious and potentially lethal disorder. It involves inflammation and cellular injury to the pancreas, leading to leakage of pancreatic digestive enzymes into the pancreas itself. Hemorrhagic pancreatitis can result in retroperitoneal blood accumulation. Risk factors for acute pancreatitis include biliary disease, hypertriglyceridemia, hypercalcemia, infections, and excessive alcohol ingestion. Excessive alcohol increases duct permeability, increases protein content of pancreatic juices, decreases bicarbonate levels, and hinders trypsin inhibitor. Symptoms of acute pancreatitis can be quite severe. These include sudden onset of severe abdominal pain, often radiating to the back. Patients may also experience nausea, vomiting, diarrhea, decreased bowel sounds, abdominal tenderness, guarding, distension, fever, tachycardia, hypotension, dyspnea, tachypnea, and jaundice. Two important signs to look for in acute pancreatitis are Cullen's sign and Gray-Turner's sign. Cullen's sign is discoloration around the umbilicus due to hemorrhage, while Gray-Turner's sign is discoloration around the flanks due to retroperitoneal bleeding. Patients with acute pancreatitis may appear pale and diaphoretic. Key labs to monitor are amylase, which elevates early, and lipase, which remains elevated for up to 72 hours after onset. Treatment is primarily supportive, including withholding oral fluids and food until abdominal pain and tenderness subside, along with pain and fluid management. Acute pancreatitis can lead to several complications. Infected pancreatic necrosis is a moderate to severe case with worsening symptoms, including new fever and leukocytosis. Pseudocysts, collections of fluid, enzymes, blood, and dead tissue occur in a significant percentage of cases. Other complications include hypotension, renal failure, atelectasis, respiratory failure, and ARDS. Chronic pancreatitis involves inflammation that doesn't heal, leading to permanent damage due to autodigestion. Chronic heavy alcohol use is a primary risk factor. It commonly develops after several bouts of acute pancreatitis, leading to fibrotic tissue development. Symptoms of chronic pancreatitis include upper abdominal pain, nausea, vomiting, weight loss, diarrhea, steatorrhea, and malabsorption due to a lack of pancreatic enzymes. Steatorrhea, or fatty stool, is a key indicator. In chronic pancreatitis, amylase and lipase levels may be only slightly elevated or even normal. Serum calcium and triglyceride levels should also be checked, as hypercalcemia and hypertriglyceridemia can contribute to pancreatitis. Treatment for chronic pancreatitis may require synthetic pancreatic enzymes to aid digestion. A low-fat diet with small, frequent meals is recommended. Hydration is important, and patients should avoid caffeine, smoking, and alcohol. Diabetes may develop if beta cells are destroyed. Thank you for your attention. We hope you found this presentation helpful. Please subscribe, like, and share to support our channel, New Teen TV, and continue to study smart.